session in the series. Last time we had two very nice talks, one by Jayanth and another by Dr. Chasanal Rathod, explaining the kinetics and kinematics of gait analysis. Today, it's time more to interact and less of talking. And we have three excellent cases today, which are going to be presented. And first of the talks comes from All India Institute of Medical Sciences. Dr. Venkatesan is going to discuss a case. We'll discuss three cases today. So Venkatesan, can I request you to share your screen and start with your case. As the case goes on, people who are on the Zoom are free to ask questions, unmute themselves and ask, or they can put their question in the chat box and allow me to ask them. Okay. All right, let's start. Thanks.
Thank you very much, sir. Thank you for giving me this opportunity to present today. So I'll share my Word file. So today I'll be presenting a patient in which we felt that we were not 100% in our gait reporting, but still I wanted to present it here because I wanted to gain from your experience, especially the senior people in this auditorium. So today we'll be discussing a patient who is a 13-year-old male who is roughly around 45 kilograms in weight and 141 centimeter height, and who is a GMFCS level 3 patient, a patient of spastic diplegic CP. So this patient had this is our routine gait proforma. So this patient had a full-term vaginal delivery, but he did not cry immediately after birth, and he had an NICU admission for 12 hours. Although MRI was not done immediately in the early childhood, he did not have any history of seizures. The parents noted a gross developmental delay by the age of 6 months because his sitting was not good. Presently, they are saying that he sat without support at 3 years of age and started standing and walking with support at 4 years of age. No physiotherapy was started until 4 years of age. That's what is the predominant history in my patient group. They come present to us very late in the course of the disease. The patient had a bilateral hamstring lengthening, which was performed in 2014. So at the time, I think he was roughly 6 years old, and he had a hip release bilateral, psoas release at the rim, which was in 2016. So after the surgery which was performed in 2014, he was prescribed AFOs, and he is still wearing them. But today I will be presenting the reports of gait analysis without AFO. With AFO is not available to me today. He does not have any history of any Botox injections. So with the present history, he is able to stand and walk with support only, and he has severe balance issues. He cannot control his walking pattern. And during walking, he has kind of a circumduction kind of a gait. And he is able to walk only with support. And the parents had noticed an equiness while walking and a possible anterior pelvic tilt. So with this in history, should I go to the examination, or should I first show the standing and walking gait videos?
Yeah, so we can have a look at the videos, but I'm very surprised that parents complain of anterior pelvic tilts. This is something even clinicians.
Yeah,
no, I'm not. I'm just taking in a light mode.
Yes,
yeah.
More of like a technical genre which we had put means.
No problem. Yeah. So I think we'll go in that order. After the history, let's see the patient walking, because the patients are brought to the clinics, and that's what we see for the first time, and we'll follow the same order.
Okay, sir.
And they then go on to the static examination findings on the bed. And after that, we'll follow with observational gait analysis details and a 3D gait analysis.
Okay. Yeah. A second, sir. I'm not sure.
Okay, so if you're not able to share, you have to, open the file
Yes,
and
sir.
then go to share screen,
Yes, sir. I'm doing
and
that.
then whatever is seen on the screen will be shared with us.
I understand, sir, but for some reason, the video file, which is in the Films app, is not being shown here. So I'll try a different app for running the video file.
Okay.
Just a second, sir. Windows Media Player.
So as
One more time, I'm trying to.
yeah, as you're doing, sharing, searching the file, few question I want to ask you.
Yes, sir.
So, ask Jayanth actually. Jayanth, when, one statement he had made was loss of balance and, okay, now we can see the file here. All right, let's go on.
Just a second, sir. I'll try to. So these are the standing views. I'm sorry for the scaling. It's not scaled properly, but you can see that he is able to withstand with support only. From the front or in the coronal plane, he is standing with more weight on the right lower limb, and his left lower limb is slightly externally rotated. And when you look at it from the sagittal plane, his hip is in mild flexion and knee is in mild flexion, and the heel, especially on the left side, appears to be off the ground.
All right. Jayanth, any comments on these pictures?
I'll just play his.
Yeah, these are just standing videos.
Yeah. So that's pretty good. We can clearly see the subject. Even though the cameras could be adjusted slightly better, there's a little tilt on the camera. So
Yes,
I would suggest that the lab people adjust that.
Yes,
and also it would be a good idea to have a plain background behind where the cameras are. So
Okay.
rather than having a lot of signage and clutter, it would be good to have some kind of plain background, any color of your choice. So both the cameras are tilted slightly by about 10-15 degrees, and that just creates a little problem when you sort of start looking at it. And I think the coronal camera could be zoomed a little better. And the other thing we do is to mark the knees and mark the heel. So you mark the knees with a circle and a cross in the middle, and you mark the heels with a straight line. So when you see the subject walking away from you, you can clearly see whether the heels are in varus or valgus. Just a few comments on how the video could be video quality could be slightly better.
Okay, sir.
Overall, this patient is holding up very well. Just able to stand with support, single hand support on the right side. And overall alignment also looks fine apart from little heels off the ground, the knees in little flexion. And actually, if you see from side profile, he's tending to lean little backwards, and that's what we at least see from these photographs. Yeah, go ahead, Pankaj.
Yes, sir.
Anything else from anyone else, participants? If there is any other point, otherwise we'll go ahead. Yeah, let's go on.
Yes, sir. Just a second. I'll pull up the walking videos. So can you all see the walking video, sir?
Yes, we can see.
Yes. So I'll just try to do the enhancements and see if we can. So this is his left foot in the swing phase. He's having initial contact in the forefoot with the ankle in equinus. And as he goes into the second rocker, there is, I don't know, whether it should be called a reversal of a second rocker. So he had some loading response in the knee, and his knee is able to completely extend over the mid stance, and he has a very attenuated third rocker. This is with regards to the left foot. So,
Chasanal, would you like to comment on that? His walking videos from front and side.
Yeah.
What all information?
should I play more, sir?
Yeah, can you just play?
Yeah, keep playing as she's talking.
Mhm. So, so we can start with the sagittal plane first, because the concerns are more on their part from the sagittal plane, and along with that, we can see the coronal plane as well. And I'd like to go from distal to proximal. So I'll say that the ankle, if we look at the right side, the foot is, the initial contact is not the heel. And at the coronal, the foot progression angle is slightly more externally rotated as compared to the normal. And to the knee in the mid stance, it didn't seem straight to me. There was slight flexion at the knee joint. And in the coronal plane, the knee tends to go externally rotate. The kneecap tends to rotate more externally in the coronal plane. And same is happening in the hip. There is more of external rotation. Maybe he's trying to clear the lower extremity and trying to circumduct. That could be one of the reason. Or second, I think there could be weakness of the hip flexors. Maybe that is one. And third, I would think there is a residual equinus, because of which he's having all of these issues in terms of not having an initial contact, and that's how a compensatory external rotation and an additional hip circumduction. So I think these are the clinical, these are the findings on the gait, and with more of clinical correlation, probably we could figure out what the impairment is.
Yeah. Please play the side view.
Yeah.
Atul, any other additional input? So Chasanal very well mentioned.
Yeah, the
that clearance
pelvis
seemed to a problem.
Yeah, so the
Of course, there is an
pelvis.
issue with stance and stability, but more often you are seeing the foot being dragged along, you know, the toe getting dragged along, and he's not able to clear the ground that well. Anything else from the video you would
I
like to
think
comment?
there are some, so there are some more additional finding at the pelvis. There is an anterior tilt and there is a retraction and protraction happening as well. I think, yeah, I think it's more of unable to clear, and none of the prerequisites of the gait have been normal gait are maintained here, none of them. So.
Atul, are you there? Anyone else wants to add anything to what Chasanal said?
So the
So
main
yes, Jayanth.
question now is there is equinus. So we would like to know whether this is true equinus or apparent equinus, or both. So the physical exam findings, this will help us to focus our clinical exam findings on that. And the child has already had a hamstring release and a hip flexor release. So we'll have to work out what is the cause of the anterior pelvic tilt, whether there is a hip flexion contracture. Transverse plane looks okay, coronal and transverse looks okay, other than the abduction and external rotation. So main data that we want from the physical exam relates to the sagittal plane.
I think Venkatesan, you should play it at a normal speed, because you know, of course, for details you need to play it at a slow speed, but you know, sometimes you don't get an idea as to whether the child is what speed the child is walking. So first, always you should play it with a normal speed.
Okay, sir.
And then slow speed. What were your sort of, after seeing the video, you know, and then you advise a 3D gait analysis. But before that, let's go to examination finding, and then let us at least list down what we want to see on gait analysis for this child.
Okay, sir. Sir, should I play another video which is in the patient walking away from the camera?
You can.
Yeah, thank you. Just a second, sir. I'm pulling up the video. I hope you can see the video. I'll just play it in normal speed first. I'm just playing it. Okay. Can you all see, sir?
Yeah, we can see this. So, he is walking with a broad-based gait, and there are hardly any angular movements taking place. So, of course, we see that he is landing on his toes. So there is issue with first and second rocker, and all of us also see that there is mild knee flexion deformity. So whatever Chasanal mentioned, we are able to see the same thing. So there is a asymmetric, which is very obvious here. And we see that he's tending to tilt more on the right side. The pelvis is also oblique, and this can be very well visualized from behind. And we'll try to correlate some of these findings on walking with examination findings. Let's go on to examination findings.
Okay, sir. So should I run the video and just present the examination findings?
Yeah, as you want, no problem.
So when we looked at the physical exam, so starting from the below upwards, so with the bilateral foot, we thought that there was a midfoot breach. Where at knee at 0 degree of flexion, means with knee in full extension, both the feet were in 10 degree of plantar flexion. When the knee was flexed to 90 degrees, the right foot had a 10 degree of dorsiflexion, but the left foot came only up to neutral. So both the feet had a plantar flexion range of motion up to 45 degrees. And inversion and eversion, roughly we could say it's inversion of 25 degrees and eversion of 15 degrees. With regards to the knees, both the knees were having a range of motion from 20 degrees from 10 degrees to 110 degrees. With regards to the popliteal angle, the unilateral popliteal angle on the right side was, both the sides were 45 degrees and the bilateral were 30 degrees. And with regards to the Duncan-Ellis test was positive bilaterally. Phelps test again appears.
At what angle was it positive? At what angle? Getting pelvic lift off. What angle of knee flexion?
If I'm not wrong, I think it was like at 80 degree of knee flexion, there was lifting of the pelvis.
You can take the video, Venkat, and just go back to the presentation. If you have the data, we can just look at it.
Okay,
yeah, that would be.
Yes, sir. So I'll do that, sir. So can you see my word file, sir?
Yeah, this is much better because then we can just see the data.
Yes, sir. So this is how we have documented the examination findings. So with regards to the hip, he had a Thomas test.
There is knee recurvatum. Is it your
No,
knee
sir.
extension of 20 degrees?
No, sir. It was not a recurvatum. I'm sorry. It was a flexion deformity only. I think
flexion deformity of 20 degrees and further flexion up to 110.
Yes, sir.
Okay. And popliteal angle, you're saying 45 degrees.
Yes, sir.
Okay.
All right, go ahead. 13-year-old is not bad to have a unilateral popliteal angle.
Yes.
It's probably in the midst of his growth spurt. So I wouldn't
consider a 45-degree popliteal angle in a 13-year-old boy as necessarily being abnormal. So
Okay.
it's outside the normal range.
Yes, sir. So just to remind you, sir, he also had a bilateral hamstring release at the age of 6. Yes. Okay, sir. So, and then with regards to the hip, he had a flexion deformity of 20 degrees on the right and 10 degrees on the left as per the Thomas test. And the further range of flexion was up to 110 degrees. And with regards to the rotations at the hip, he had a 70-degree internal rotation on the right and 75 external rotation on the right. Whereas on the left, the internal was 55 and the external was 75. And with regards to the abduction of the hip, with the knee in extension, it was 45-degree bilateral, and the knee was flexed to 90 degrees. The abduction angle increased to 60 degrees. And this is a manual muscle testing which we do, sir, from our physios. And I know that it's very difficult to be very confident with these values in a CP child, but still we kind of get this done as part of the routine examination. So can I go further, sir? Or do you have any questions in the examination?
Yeah, let's go ahead.
Yes, sir. So in the standing views, this is a description of the video, which we have just seen. We thought that the patient was standing with support with the bilateral hip of the ground and hip and knee in mild flexion. And the ankle seems to be in dorsiflexion predominantly because of the midfoot break, means the midfoot break giving rise to that kind of a posture. And that was a suggestion of an anterior pelvic tilt. With regards to the video, we thought that the initial contact on the forefoot, first rocker was absent, and the second rocker was prolonged and reversed, and the third rocker was attenuated according to us, and there is reduced clearance in the swing phase. In the coronal plane, if you accommodate for the midfoot breach, I think the foot progression angle was okay. And on the left side, it seemed to be a mild internal. With regards to the knees, the initial contact we thought was roughly at 30 degree of flexion, and the loading response was present bilaterally. And there is reduced peak knee flexion in the swing phase. With regards to the hip, we thought that the flexion of 30 degree was observed. Reduced extension was noted in the stance phase. And with regards to the pelvis, we thought there was a circumduction gait and an anterior pelvic tilt with a small amount of lumbar lordosis. Should I pull up the gait report, sir? Or should I just describe the findings?
We should
Go ahead
see
in
the
the
graphs.
same order.
Yeah.
Yes, Chasanal, you wanted to say.
The graphs, sir, if we could see with these, yeah.
Yes. So I'll stop sharing the screen.
Can I make a comment, Dr. Venkatesh?
Please, sir, please do.
There's a couple of things. I think apart from the clinical examination, if you just give us 4 information, one is whether what is the child's cognition, whether he's got selective motor control, whether he can stand on one leg, supported or unsupported, and whether he can do a kneel standing. So we've got this algorithm where if you have 4 of these present,
yes, sir,
that means he can do kneel standing, single leg stand, good cognition and selective motor control. It just gives us an idea of what his ability will be, because if you can include that as part of your examination, it will be a great help.
So if I'm not wrong, sir, one is cognition, single leg stance, and kneel balance. And what's the 4th one, sir?
Selective motor control.
Selective motor control. Okay, sir.
So it also gives you an idea about their rehabilitation potential.
Okay, sir.
Motor control, yeah.
Yes, sir. Sir, as this was, I do not have the entire data today. So whatever data I have, I present today. But for the next time, I'll ensure that we'll get these data also, sir.
If you can just show us the graphs, Venkat.
Yes, sir. So you don't want to look at the parameters, sir, temporal spatial parameters straight away to the graph?
No, we can look at spatial parameters.
Yes, sir, please.
And we should.
So if you want to just present the stride time and the stance time has increased, in fact, more than doubled. The swing time was increased more on the left side than on the right side, and the swing phase percentage has decreased. So we thought it's probably due to balance issues. The single support phase percentage has decreased, and the double support phase percentage has increased by more than 2 times. Cadence has decreased by 50% in comparison to normal values, and velocity decreased by 4 times in comparison to whatever normal values are there. The step length was reduced by almost 50%, and step width has increased by 3 times. Okay, sir. So let me move on to the.
So he's walking very slowly with a poor cadence and a very wide base of support.
Exactly, and reduced stance phase.
Yeah.
Sorry, reduced swing phase. Yeah. Okay, sir. So these are his gait profile scores and the gait deviation index. And should I go to the graphs? Yes. So should I zoom out a bit?
So if you could just go to the GDI and GPS.
Yes, sir.
So for the amount, so the GDI and GPS basically relies on the variation of his kinematics from normal.
Mm-hmm.
I don't think it takes into account much of the weakness and the wide base of support. All that does not go into the GDI. What goes into the GDI is in terms of pure kinematics of gait, how well he is walking, yeah, how close is he to normal on the kinematic graphs. Okay. And you can see that he's for the amount for how significant his gait problems are, he's scoring very highly on the GDI, right? He is just 2 standard deviations away on the GDI. Someone who is as severely involved as him, who's GMFCS level 3, should have a much lower GDI, yeah? But he doesn't, because he, in terms of kinematics, he's okay, which you will see on the graphs. That's the point I'm making. You would expect his GDI to be something like 50 or 60, but it is not. He's scoring very highly, 75 to 80 on the GDI, which is a slight discrepancy. Yeah.
Yes, sir.
So this is what what Abhay always means by he's walking straighter, but I don't know if he's walking better. So
exactly.
this doesn't signify the quality of his walk. It just tells us that there are no major angular issues.
Yeah, no abnormal patterns of his joints compared to normal, which you can clearly see on the graphs. He's very close to normal on most of the parameters.
Yes, sir. So should I go ahead interpreting it, sir?
Yeah.
You have to blow it up a little so we can see it.
Yes, sir. The right side, the initial contact was at 5 degrees of plantar flexion. First rocker was reversed, and the second rocker was absent, and the third rocker attenuated, and the foot remains in plantar flexion in swing. On the left side, initial contact at 8 degrees of plantar flexion noted and follows the same pattern. On the right side, the initial contact was in 10 degrees of external rotation of the foot, and the foot progression continues in external rotation throughout the gait cycle. I say on the left side, it was 20 degrees of external rotation. With regards to the knees, it was initial contact at 30 degrees of flexion, loading response absent, knee flexion reduced and prolonged peak knee flexion. And on the left side, it is almost a similar with the initial contact at 20 degrees of flexion. And with regards to the hip, the initial contact is at 40 degrees of flexion, reduced extension in stance, followed by normal flexion in swing on both the lower limbs. On the frontal plane, the initial contact of the right foot is in 20 degrees of abduction, and hip remains in abduction throughout the gait. On the left side, it was in neutral, followed by normal pattern throughout the gait cycle. With regards to the transverse plane in the hip, the initial contact is at 8 degrees of internal rotation and continues to follow a normal pattern. As on the left side, the initial contact was at 10 degrees of internal rotation and continues to follow an internal rotation throughout the gait cycle. In the pelvis, on the sagittal plane, we have a 20 degree of anterior pelvic tilt. And on the frontal plane, the pelvis is down on the right side by 7 degrees and up on the left side by a similar angle. With regards to the transverse plane, the initial contact has a 10 degree of protraction on the right side and increased protraction during stance phase of the gait cycle. And opposite is for the left side, means 10 degree of retraction, reaching to neutral in stance phase. And external rotation in swing phase of the gait cycle. So this is the summary which we had done with the kinematics. And if you have any other inputs, sir, I'll be happy to.
So, Venkatesan, we have seen the patient walk.
Yes, sir.
We have clinical evaluation. Now we have these graphs of 3D analysis.
Yes, sir.
So, can you just summarize what are the most striking 3 points on a 3D analysis which you see on these graphs, and what would be your interpretation based on that?
Okay. So one thing which is striking for me is the patient has an unstable and a circumduction kind of a gait pattern. And the principal issues, the number one is the unstable gait noted by increased stance phase, increase in step width, and reduced swing phase. And there is a true equinus on the left side. And probably there is an equinus on the right side also, but it is not showing up in the graph due to the midfoot collapse. And these are the 3 main issues I can note. Of course, there is an initial contact of the knee inflection with reduced peak knee flexion and a prolonged peak knee flexion.
So what would that suggest? Reduced peak knee flexion and delay. You have two points here.
Yes.
The peak knee flexion has reduced and it is also delayed.
Yes.
The peak is also delayed. So what would that be suggestive of?
The delayed peak knee flexion means that there is possibly a rectus spasticity or a contracture, and reduced peak knee flexion can be due to multiple issues, maybe because he has not got enough hip flexion range of motion also. And other thing is, I'm not very sure, because looking at the graphs, since the initial contact is happening at roughly 20 to 30 degree of flexion in both the knees, there might be an element of hamstring tightness also.
Was it
Any
Duncan
other
Ely was
comments?
negative, isn't it? Duncan Ely was negative.
Was
No, sir,
positive.
it was positive, sir.
Was positive, is it?
Yes, sir.
Yes.
Okay.
So I think other reason could be the external rotation, because it gives us a false feeling of decrease. The cameras pick it as a false or a not a normal swing knee flexion. So every time the knee goes into external rotation, those patients also give us decreased peak knee flexion. Here the rectus is positive though, so that could be one of the reasons. But other thing to look for is the rotation, which might also be giving this.
Could you just blow up the zoom in, zoom the whole?
It's around 40 degrees, sir. It's still above.
Yeah. So there are 3 things on this knee sagittal plane graph that worry me, and when all 3 happen together, then I'm thinking this is true stiff knee gait rather than stiff knee gait, sort of false stiff knee gait, which happens because of walking slowly or because hip flexion power is not good. First is the peak knee flexion is decreased. Number 2 is the peak knee flexion is delayed. The timing of peak knee flexion is delayed. And number 3, the slope of the graph, which is what is the acceleration of the knee shank segment in swing, that slope of that curve is significantly reduced compared to normal. So you can see that the normal slope, and he is going into almost full extension in stance, pretty good for a JMFCS level 3 who's standing in crouch. So along with a positive Duncan Ely, I think there are multiple indicators, independent variables here, which are telling me that perhaps this is a case of a true stiff knee gait. Taral and Chasanal and Atul.
Yeah, I would tend to agree with both the points, Chasanal as well as Jayanth, that if he did not have an external foot progression angle, then this represents the true effect of rectus tightness. In presence of a external rotation foot progression angle, the effect of rectus tightness on a sagittal knee graft tends to be exaggerated. But even if you give concession for that exaggeration, this does represent a significant sort of findings of delayed and reduced peak knee flexion, and this in conjunction, in connection with prone rectus test being positive becomes significant. And on visual gait analysis, we are seeing that the child does have issues with the swing face. He has issues with clearance. So all these three things go hand in hand. So they are not contradicting each other, but they are supplementing each other. Chasanal, what would be your
the same thing, sir, what I added before. And other thing, Dr. Venkatesan, how much duration since the surgery this analysis has been done?
So he is now 13 years old. His first surgery of hamstring release, it was not a transfer, it was a release. It was done at the age of 6.
Okay, so it's almost 6 years. So in immediate post-op gait analysis, maybe 6 months or less than 1 year could also show such graphs. But here it has been a long time. So probably the reasons are the rectus, of course, and the external rotation also, which I would kind of add to this.
But Chasanal, the foot progression angle looks reasonably okay. If you look at the bottom, this is a BTS thing. It will be slightly different.
I saw them. Yeah.
It's the bottom right one, foot progression. That looks reasonably within normal limits. And even his hip grafts, if you just go up a little bit,
before I go up, sir, I just want your opinion for the ankle. Like, what is the plan for the ankle? In the ankle, at least on the left side, there is definitely a true equinus. But on the right side, maybe because of the midfoot collapse, we are not getting that equinus. So what would be your suggestion for the ankle, sir?
I thought he had good, does he have an equinus contracture, a gastroc contracture at the ankle?
Yes. He had on the clinical exam, the knee is in full extension.
I would be very reluctant to release the gastroc in a GMFCS level 3 13-year-old child. Okay. The reason he is getting that much knee extension is because of the calf power. He's able to harness the plantar flexion knee extension couple to push his, not only to get much better stance phase knee kinematics. And as Paula Selber used to say, that knee extension and stance is a prerequisite. Knee flexion and swing is a luxury for a child with CP. So I can see that his feet are off the ground, but you have to be extremely careful before releasing the calf, because that is an important power generator for him and he's already weak. Any other thoughts on that? By the book, you will have to release
in presence of knee flexion deformity of 20 degrees, no? You would not touch those ankles, you don't want to correct that.
Sorry, sir, please go ahead, sir. Please come again, sir.
There is a knee flexion deformity of 20, which you mentioned, which is also seen in the initial contact. Knee is in quite a bit of flexion on the right as well as left side.
Yes, sir. So we should not touch the ankle, is it, sir?
Maybe additionally, if you do a solid AFO gait analysis of the same child and look at how the knee is acting, and maybe if the knee flexion corrects a bit and gets the ankle down, we don't know if it's apparent. Always the patient has an additional equinus like 10 to 15 degrees. So at least while walking, which I have noticed. So it's part of the probably a developing stiff knee gait, or maybe he's just about to be there, or he's just in the borderline, like from getting corrected to a crouch and he's gone towards more like a stiff knee looking pattern. Not although the angles don't suggest that, but he's just borderline. I mean, anything 10 degree below, he would have been a stiff knee gait. So again, in that case, we would not address the gastrope there and
Okay.
just give him an AFO modification instead.
Okay.
Sir, any sort of opinions from their biomechanists here? So Mihir is here, Ankita, and then we also have Mayuri. Any of one of you, want have some additional comments on this? Please let us know. Mihir, would you like to, share your comments or opinions from these graphs and this patient?
Hello, sir. Good afternoon to all of you. It's afternoon here in London. Sorry. So, yeah, I would completely agree that we can try. I mean, the ankle should not be touched because it looks like a stiff knee gait. At the same time, the right limb has more of a stance phase, and the left limb has reduced stance phase as compared to the right. But there is a lot of stiff knee gait seen in the left knee than the right. So, I mean, in that way, if you can suggest any other intervention, to address these more stiffness on the left knee, as compared to the right, what was the difference? I mean, how can it be addressed?
So, so these are gait findings, and in association with his stability, his power, and whether he's mover or shaker, how quickly he can move. The intervention can be decided. What is surprising again here is, you have prone rectus test positive, very strong indication of rectus tightness on sagittal knee graph. However, pelvis doesn't reflect that. You don't have any bearing of rectus tightness happening on the pelvis. Looks pretty stable, for the type of rectus tightness it would show.
Yeah, could we just go up a little? Yeah.
Yeah.
And
Yeah.
blow it up
So
a
Jen,
little.
what do you feel about that?
Exactly. So I would, you're absolutely on the money there. I would expect more perturbation to happen, to see more perturbation at the pelvis, because the so-called double bump pattern, I'm increasingly convinced that the rectus has something to do with it. But I don't know whether the previous hamstring release that he has had may have changed this, the double bump pattern. Typically when we have this classic stiff knee gait, we do see some double bump pattern, but I'm not seeing so much of it in this particular case. So I don't know what Chasanal is shaking her head. I really like to.
No, the same thing, sir. I was also wondering the same, that considering the rectus, the pelvis is not that anteriorly tilted.
Yeah.
Remember, sir, he has undergone a bilateral psoas release at the brim at the age of 8 years. So in 2014, he had a hamstring release, and in 2018, I think 16, he had a psoas release. So whether my question for the entire panelists here is, like, what is it that is causing his foot to go into an apparent external rotation or a circumflexion during his swing phase? Like when he's walking, we can see that.
That's for clearance, because he's not able to flex the knee.
Yes, sir.
So he has got a wide base of support because he has got problems with stability and balance and strength.
Yes, sir.
So that's why he has a wide base of support. That's the first thing. Second thing is, the reason he is swinging his leg around is because he's not able to flex the knee. So we could go into the kinetics and get some more idea about what are his hip powers, and that might give us some idea about how things are. Yeah, he's not generating any power at the hip at all. And in fact, he's not generating any power at all at any of the joints. You can see how his
even at
power graphs are
ankle,
completely
hardly
flat.
any power generation.
Yeah. So it's clear we have documentary evidence that he's extremely weak, if at all, I would offer very limited surgery. But certainly what Chasanal said is true. I would put him in an AFO and again analyze him with an AFO to see whether there is any change and what change there is in his gait. That's the first thing I would do. And based on the available data, I think the only sort of procedure or intervention that comes to mind is a simple rectus release rather than doing any transfers because he's a level 3. Just a simple rectus release would be the most I would offer to this boy.
Distal rectus release.
A distal rectus release, yes,
Yeah,
distal
distal.
rectus release.
One more question here, sir. So if in generally for patients who have balance issues like him, what should be the usual treatment method to improve his balance?
Physiotherapy.
Physiotherapy, okay. Any specific points of physiotherapy, sir? Anything like any specific?
No, there are much better physiotherapists on this on the panel than me. So any of the therapists can kindly
and one last question, sir.
Answer the point.
Once they had spoken, I just want to add one last question. So my last question is like, you mentioned that in a stiff knee gait, you should not release the gastrocnemius. So what is the specific reason? Does it mean that he will go into recurvatum? Is that the reason? Okay. Okay. So if to conclude this case, I would say like he should first focus on physiotherapy. I should have a gait analysis following an AFO and see how he's behaving. And is there any use of correcting the midfoot breach or the that he's getting to improve the liver arm dysfunction, sir? Is there any?
If you get a standing X-ray of both the feet and we see how bad the talonavicular uncoverage is, maybe that can be planned. But I think AFO would be a better choice to even hold that. It doesn't look that bad.
Okay.
And I had one question or maybe a comment that now we have not stopped doing more of SWAS releases. Jayanth sir, Taral sir, and Atul sir and Tushar sir, I would like your opinions also on this. That any particular criteria or particular cutoff point where we would want to go for SWAS release, which we have changed over the period of time. And of course, with the gait analysis, we do less of SWAS release. So is that also one of the reasons why this patient is having more of stability issues and problems around the hip in terms of clearance also?
Yeah, Jayanth, let's start with you and then Atul.
Okay. So I 100% agree that having a gait lab has certainly changed our practice with regard to doing fewer SOS releases than previously. And I do agree with Chasanal that the SOS release has significantly reduced the hip flexion power and therefore the ability to accelerate the hip inflection and early swing. And that may well account for the apparent sort of stiff knee gait pattern or lack of knee flexion. So that is the main issue that we are all debating now. Is the stiff knee gait pattern because of true rectus tightness or is it because of weak hip flexors? And really, we have no single tool that will really give us a clear answer as to which of the two it is. And in the end, it is a judgment call that we need to make. Because it's a very, very difficult issue to sort out very clearly.
Atul, you want to add anything to what Jayanth?
I just had one comment to make here that, when we do a gait analysis, we are seeing just one function which a person with disability needs in life, which is walking. There are many more functions which are required. One of the function is climbing up the stairs. And when you release psoas, you lose the hip flexion and inability to climb a stair or uh, uh, um, uh, go over an obstacle. It's definitely felt when the hip flexors are released. So cutoff point, Chasanal, you asked about the cutoff point.
Yes.
So unless the hip flexion deformity is significant, which is more than 30 degrees, we don't tend to release any of the hip flexors.
Yes.
So that's the answer. Another thing which is very important while doing before rectus release, which what I've realized is one of the important section of rectus function is to get up from a sitting position, where you need to stabilize the pelvis in flexion, and then you need to extend the knee in order to get up from a sitting position. So if this child has to go to a college or school or sit in a vehicle and get up, he's going to require his rectus. And you really have to balance. Just because there is a stiff knee gait and there is delayed peak knee flexion and a decrease in peak knee flexion, that's not an indication to do rectus lengthening. I would definitely would like to see this child getting up from sitting position. And if he's not swift with that, and if he's already having trouble, then I would be reluctant to offer him that gait corrective surgery. We don't want to correct the gait and have difficulty with another function. So these things are very important, and this is what we have learned today from this case. You have equinus, but in correcting equinus, you will potentiate his crouch gait. You will, in fact, give rise to an iatrogenic crouch gait. So you cannot do gait corrective surgery by looking only at one part of the joint. You have to look at each joint in 3 planes, and then also look at all the joints together and equate that with function of the child while walking, while stair climbing, while getting up from sitting position. All those things are very, very important for taking a decision. What I would also, comment about this case, it's a very well collected data. The few points we would like to add to these data. One is on clinical examination, kneeling, which is very, very important. Documentation of kneeling, supported kneeling, unsupported kneeling, balanced kneeling, unbalanced kneeling. All those things are important. In terms of gait analysis, Chasanal already mentioned that we would also like to test his 3D gait analysis with an AFO, and that would give us many more points. And third thing I would like to add here as data are the X-rays. We would like to have X-rays of both feet AP view to see if the foot is what is the talus metatarsal angle. Is the talus is there a lever arm disorder in the foot? We would also like to have X-ray of both the knees lateral view to see if there is patella alta, what is happening to the knee joint, how much is the flexion deformity. It goes without saying that we would definitely like to have X-ray of pelvis with both the hips to see if there is any subluxation or rotational problem at the hip level. And last but not the least, if possible, I would also like to get a rotational profile. Any child who has this significant amount of pelvic rotation, as you are seeing here, we would like to get a CT rotational profile to see if there is any structural torsion in tibia or femur. So, that would be additional homework for you. And with this, I think we would, end this case. If people have any comments or questions to make or questions to ask, we still have 5 minutes on this case, and then we can end. Atul, you have anything more to add?
I think Taral, you've covered most points. In my early days of practice, I was doing a lot of psoas release over the brim, what we were taught at Sick Kids. And, their criteria was more than, because they didn't have a gait lab at the time. And they really went by more of clinical findings. If the FFD was more than 30 degrees, with classical jump posture, we would do the bilateral psoas on the brim. And I practiced that when I came back, and I take that point of yours. As these children got older, they definitely had difficulty in climbing steps, and I've now almost stopped doing any kind of psoas release unless it's a non-ambulatory child with severe FFD. Then I would release the psoas, release the rectus proximally to improve the hip position. If they want to do kind of support walking, so GMFCS 4, they just want to be like a functional ambulator to get the leg in position. Other point is, this child had surgery done very early, around 6 years. Is that right, Dr. Venkatesh?
Yes, sir.
6, 7 years. Now, at that age, they are still evolving in the GMFCS scale. And I think the intervention was a bit too early. Perhaps the child was very tight, so it was appropriate at the time. But I think one should defer if one can, or do minimum, guarded releases or transfers to try and maintain the power. This is not unusual when the child gains weight and, as an adolescent, you get this typical external rotation pattern because of weakness of the quads, the weakness of the hip extensors. They're basically holding themselves up. So I think it's worth having additional data in terms of what Taral has mentioned. What is the functional mobility scale? So whether this child can walk 5 meters or 50 meters or 500 meters, ultimately when we do surgery, we have to know what we are improving. Are we improving his only his curve, his gait profile? Actually, we are making a meaningful contribution. So I think that also becomes important as part of the analysis. So, I think we should include that apart from whatever Taral has already mentioned. So those are my comments.
Thank you,
Thanks,
sir.
Atul. And the last point I would like to add is you have to ask parents what they want. If the aim of the parent for seeking treatment, if mother says that I want my child to walk without any support, it's not going to be achieved by doing a rectus lengthening surgery. By doing a rectus lengthening surgery, his clearance would improve, his stiff knee gait would improve. But if what parents and the patient wants is better stability, it's not going to be achieved. So it's very important to know what are the functional limitations the parents and the patient are worried about and what they want corrected. So, that's another chapter by itself. So thanks, Venkatesan, for sharing such a nice case. A lot of learning points for all of us from that case. We are running a little short of time, so I will allow one more case. Chasanal, please
Yes.
share your screen. Venkatesh, unscreen, unshare your screen. Let's
Yes,
move on to the second case. The Jayanth's case, I think we will have to keep it along with Dhiren Bhai's talk, which is happening in second Sunday of April. Okay, so we'll make that announcement at end of the case discussion by Chasanal.
We've got
Thank
to
you.
7 o'clock. So we continue with one more case.
So I have a very simple case, and actually we had planned to have this case in the first webinar. So it is just concerning the sagittal parameters and gait deviations. So I'll start with the case. This is a 7-year-old child, and currently the concerns of parents are that he has a toe walking on the right side, and this deformity has been progressing. The child has not undergone any intervention so far, and he's on and off therapy. The one of the reason is COVID for having little lack of therapy. He has a solid AFO currently, which he has outgrown, and the left hand here he's dominant, and as we see, he's a right-sided spastic hemiplegic CP. He's a very good high-functioning CP child, as all the hemiplegics are. Intelligence, cognition is very good. Bimanual activities are very good with the upper extremity. He's GMFCS1 and he enjoys lots of sports activities. And even with this, he has been very active and mobile with all the activities currently. And he doesn't find it as any hindrance or need for surgery. It's the parents who are concerned about this, basically. So if we look at the more of positive and important evaluation, he has a very good core strength. Coming to the hip, he has a very equal and normal combined hip abduction angle in extension as well as in flexion. And he had no hip or knee FFD as such. His functional popliteal angle has been 0. And for the knee, his R1 is around 50 degrees, R2 is 40. And his functional popliteal shift is almost 0 with a 30-degree range of movement. So the knee and hip were quite good, and also the trunk and core is quite good. He has no extension lag, and the prone rectus test was negative on each of the sides. And coming to the important point here is his ankle. So his R1 is around -30 plantar flexion, and his R2 doesn't change much. And on flexion, the silver scale test from 30, there's a 10-degree change in the plantar flexion. And it suggests more of a distal involvement of the gastrosoleus, and it's a fixed contracture. So that's what I would kind of conclude at the end of evaluation. So I think here clinically the concerns are only at the foot and ankle level, and proximally everything feels good on the clinical evaluation. His rotational profile, that is versions, are normal and good on both sides and equal. And also the tibial torsion seem normal. Only on weight bearing, the feet slightly goes into external rotation, but I will see how it is in the gait analysis subsequently. He has a very good selective motor control, except for the contractures, which the range of movement could not be possible, and we couldn't get the SMC score here, but it is quite good. And looking at his gait analysis.
Chasanal, yeah, before that,
yes,
can we go through some of the examination findings?
Yes.
So one thing what I noticed was that probably, I'm not very sure, but is there an exaggerated cavus also on the side? So how it will make a difference is that if there is increased cavus, it probably suggests that tibialis anterior is weak, though we are not able to test it in the light of equinus deformity. You cannot test tibialis anterior very well, but if there is a cavus deformity, it suggests that the tibialis anterior power is not going to be.
Yes. So he had a little, yes, he did have cavus, and intraoperatively I had to do his plantar fasciotomy. I think this picture, if it would have been the other way around, we could have seen. I have a couple of his squatting pictures. There is a cavus he has. And post the gastrosoleus recession, he had a lot of flexor tendon tightness as well. So this has been long-standing now over a year.
This also tells you that
yes,
if his ankle dorsiflexion power is going to be weak, we have to counsel parents that he may require ankle foot orthosis.
Yes.
For a long time, or maybe permanent, as a walking aid.
Yes.
For that child. Any other comments on examination, Jayanth, or anyone else who's present on this platform?
So one of the things I want to know in a child who's walking in this much equinus is, are they type 1 hemiplegic, type 2 hemiplegic, or a type 4? Because particularly with the amount of retraction that he has on the video and the posturing of the upper limb, I want to clearly place him in one of the Winter's classification. But on physical examination, he doesn't have any contracture at the knee or the hip. But when he walks like a type 4 hemiplegic. So I just want to know whether he's walking like that because he's got a very severe contracture at the ankle, or whether that is his underlying gait pattern. Those are my. So here it clearly says it's type 2 hemiplegic gait pattern, which is, I think correct. But if you just see the way he is walking with his hemipelvic retraction, he has got some features of type 4.
Yes. So his adductors were not tight, so actually.
Yeah.
So, but looking at this, maybe the pelvic, because it is retracted, that is giving the picture.
Yeah.
And plus the right upper extremity has a less use as compared to the left. So he's left dominant. So probably even the upper trunk and the less extremity use is causing the entire trunk to turn around along with the hemipelvis.
Yeah.
So I agree with Chasna. These all seem to be compensatory sort of findings, those in the knee and hip, rather than actual problems. And you can very well notice it on in the kneeling posture. He's got beautiful kneeling posture. It suggests that his hip is absolutely fine. On examination, the knee, there is no evidence of hamstring tightness. So all these things suggest that knee and the hip are behaving the way they are, probably because of the ankle equinus.
The severe equinus at the ankle. And that's an important distinction for us as clinicians to make, to understand what is causing, because by the book, you could easily look at the way he's walking and say he's a type 4, but he's actually not a type 4, he's a type 2, because the problems at the knee and the pelvis are compensation.
Yeah, let's go ahead, Justin.
Yeah, so I think even the opposite side, sir, if we look at it, because of the pelvic obliquity, the protraction and the trunk changes, they are evident in the EVGS also. It's not totally 0 or 1 or 2. There are still, like, it's around 6, and it is more of proximal points which are causing this. And of course, the right side, the score is increased. And so coming to the sagittal plane kinematics, so the idea was to just look at the sagittal plane instead of going through all, but actually he just has mainly the sagittal plane issues. So if we look at his pelvis here, he has little alternating crossover, plus that's what the retraction and protraction, which we have been seeing and talking about, and probably is one of the reason which is making it look like a type 4. So, and these tilts are almost, they are a little more anterior as well. I think that's because of the severe equinus. He's trying to just balance or maintain the center of the body mass, which I think is one of the reason. And because the rectus was negative and hemi, again, we would not be worried more about this. At the hip, there is on the right side, of course, because of the so at the hip, there is a decreased extension in the mid stance, pre-swing, and throughout the swing phase again. So I think that is because of the fixed equinus contracture. Had it been a little mobile feet, this could have been following the normal pattern as well. And if we look at the knee, there is increased and consistent increased flexion on the knee. And even in the mid stance, it is flexed, and it tries to come towards the normal or be straight around the mid stance, but again in the terminal stance and the pre-swing, it goes into flexion to get the clearance. And if we look at the right side, so again this a quick, although he starts with a flexion which is around 10, but I still think that this quick small little bump is just that he's doing it for a quick clearance to weight shift from this contracture there. And if you look at the ankle, there is a consistent fixed line in the plantar flexion. Unlike if it was just a spasticity, we could have seen a small, this graph going slightly up and then coming down and remaining in plantar flexion. But a consistent and a straight line probably correlates with the clinical findings and suggests that it's a fixed ankle contracture. So I think this is a very nice graph where we can clearly distinguish or differentiate between a spastic child and a contracture child. And this could be one of the patient who's a clear-cut candidate for a soft tissue release here. And if I look at the gait features and kind of correlate with the positive clinical findings, I think the only problem we have here is the right gastrosoleus contracture.
Excellent. So if you see the other ankle here,
yes,
the equinus which you see, it is compensated. It is just giving length to the other side to match the equinus on this side.
Yes.
And one should not feel that this is bilateral CP, which is asymmetrical. This is definitely unilateral CP, and this finding of having equinus on or reduced dorsiflexion on the other side in the stance phase is not because of calf tightness. And as Chasanal mentioned, it can be again correlated by the physical evaluation that on the other side ankle dorsiflexion is completely normal. And the residual knee flexion which you see all the time here, again on clinical evaluation you don't have a knee flexion deformity. So again that is nature's compensation to reduce the limb length on that side. A very, very neat graphs, and it gives all the information. Any other sort of comments from?
I think so. He has a lot of pelvic obliquity here. He's already kind of hitchhiked his pelvis a lot. And after that also he's using the knee again. So I think that's like two compensatory things he has already done to overcome this fixed equinus. And he's
so that's the reason once you have a fixed contracture and the knee and the pelvic being affected, surgery should be done as early as possible.
Early as possible.
Otherwise, the pelvic pattern gets fixed and then it's very difficult to sort of control that. Yeah, with any kind of therapy.
Yes,
And in such cases where you have one joint that is severely abnormal, I feel that correction of the joint and Gait analysis after 6 to 12 months is the only way to really tease out whether there are problems at other levels. Because the abnormal ankle kinematic is influencing the overall gait pattern so much that it's practically impossible for us to see how those joints would behave if the ankle was more closer to normal. So generally I defer, even if there is a significant problem at the knee or hip, I defer any decision making regarding that. Just fix the ankle and then have another look 12 months later.
Sir, can I ask a doubt, sir?
Yeah, please.
Sir, at this during procedure, since his tibialis anterior might have been lengthened for a long time because of the fixed equinus, would you also try to kind of do a tightening procedure, something like transferring it to the middle cuneiform in the same sitting, or will you just correct the gastrocilius and give an AFO and wait for his tibialis anterior to take over? How does it work?
Yeah, so Jayanth, we would like you to answer that, and then followed by Chasanal, because she was managing this case.
So in hemiplegics, whenever I correct equinus, I'm routinely retensioning the tibialis anterior. So that is a standard protocol that we are following for the last 3 or 4 years.
So you transfer it to the middle cuneiform with the buttons?
Yeah, I just do it like a clubfoot tiband transfer through a drill hole in the middle cuneiform, and then tension the foot at neutral. When I tighten the tibialis anterior, make sure that I don't put them into too much dorsiflexion. I just tension the tendon transfer at neutral.
Okay, so if it was a diplegic, no?
Never in a diplegic, because you would then push them into calcaneus and propagate crouch gait. This is meant only for hemiplegics in my practice.
Thank you, sir.
Chasanal, would you do that? Having heard from Jayanth.
Sir, what Sir said is true, that for the diplegics, of course, never the transfer. Even for this age group, probably I would not shorten the tiband, because I've seen a lot of cases so far. They have done very good and they have developed a good tibialis anterior power. If we give them a solid AFO post 3 weeks of plaster removal, very much strictly to be worn for around 2 months, and all walking and therapy to be done with the solid AFO, they recover the tibialis anterior power very easily. Only kids, I think, which I have done a shortening or a transfer to the just in the midfoot along the third toe line, is kids above 12 years of age. So some kids with very severe such fixed contractures with hemi, I have done transfers for them. But this kid, I'm still worried that transferring or shortening could cause calcaneus or even go in valgus. So probably I'll just wait and watch and postpone the transfer for later.
Atul, what would you do? Any more comments on that?
No, I think Chasanal has covered pretty well. And this is a interesting case. If you leave this child alone, you can see that he's going to evolve into a jump knee pattern on that side. So he'll eventually end up with a flexion knee contracture. The pelvic is hitchhiking already. I think this is a good way to intervene early. Although sometimes we get these children referred by the therapist and they would say, wait for some more time. And I think these are children where one should not wait, because you're going to have very soon asymmetrical gait pattern and secondary changes in the knee and hip after 2 or 3 years. So I think my surgical release would be gastrosolar recession, in zone 3, give a cast like Chasanal said, 3 weeks, let him walk on it. Only one comment is, when the cast comes off, the children become a bit slow and they walk. They have some great difficulty in walking. So one has to counsel the parents. They'll walk with the leg in mild external rotation. He'll walk slow. Otherwise, they feel post-surgery become weaker. So that counseling part is very important, I think. And they all recover very well. In 3 months, I think he'll be almost near normal.
Satul, I want to ask a question to Poonam. With this patient, once the equinus is corrected, what would be your strategies as a therapist to recruit the ankle dorsiflexors? What would be the methods you would utilize?
Yeah, so a lot of things actually. So as Dr. Chasanal said, So solid AFO initially, and then I prefer to wean off the child from a solid AFO for them to be, able to recruit their T-band. Of course, we're going to use all the works, the electrical stimulation, all surfaces that, unstable surfaces that force the child to recruit the tibialis, and like a wobble board, like an upward incline, gait training, treadmill training, upward incline treadmill training, aqua therapy, all of these things we're going to use. But once if that heel rocker starts coming, then you know that you can sort of go to the next step after a solid AFO. That would be, I guess, within maybe 3 months post-op to the first 1 year, so 3 to 12 months.
Right. So, I'm not a CP astrologer, but, I predict, looking at this child and his cavus, that he may require a procedure to augment his ankle dorsiflexion, maybe some tendon transfer. Secondly, a lot of patients where we have, done surgery for ankle equinus, and those who are actually walking with equinovarus, where only calf surgeries were done without doing anything to tip post. So even those, on longer follow-up, when they become 12, 13, 14, they develop external rotation gait pattern, coming from foot and the tibia. And those, they require Mosca's procedure, calcaneal lengthening procedure, and tibial derotation. So, this is 2022, and probably after 8 or 10 years, we are going to ask Chasanal again as to what was follow-up of this child, and were there any additional procedures which this child required. Of course, one has to also keep a watch on the limb lengths. Once the ankle equinus is corrected, what is the actual limb length? Monitor that, and some of these children also will require limb length correction by doing the epiphysiodesis at age of around 10 or 12 years age. So those are additional comments which I want to make. Chasanal, tell us how you manage this patient, and what's your protocol for him.
Yeah, so I just did a gastrosoleus recession for this child and additional plantar fasciotomy, and tibialis posterior was good, so I didn't do the tip post. But from the same gastrosoleus incision, I had done the FHL and the FDL also medially released. So lengthening, because the toes had gone into clawing after getting the dorsiflexion, and he went into a plaster for 3 weeks. And I don't have his follow-up gait yet, but maybe in subsequent webinars, I would.
Atul is hopeful. He's saying that the ankle dorsiflexion power will get unmasked, and we all wish that. If that happens, that will be best for this child. But we'll have to watch and see.
Yeah.
So,
sorry to ask.
Any other questions? Yeah, Venkatesh.
What were you mentioning about FHL and FDL? I'm sorry, I didn't get it.
Yeah, so when there's so much of long-standing equinus, so the FHL and FDL, they go medially and they then go plantarwards. So in this case, once we correct that much of equinus, the toes go into clawing. So if this deformity is not so bad, suppose it's just 10 or 20 degrees of equinus, then we can just add a extended plaster to stretch the toes. That helps. But with so much of deformity, the plaster will not help. And eventually when the child starts walking, he'll always do the clawing on the ground. So it's always good to intraoperatively just at the musculotendinous junction, just like we lengthen all other musculotendinous junctions, we do it for FHL, FDL also. Then it gives an additional working length to these tendons and don't cause clawing.
Okay. So you did lengthening at zone 3, is it?
Yeah, so no, I did it between the junction of 2 and 3.
Okay.
So, yeah.
So excellent. So what we've learned from this case, in summary, we got an excellent sagittal profile. Graphs of a child who is type 2 hemiplegic gait pattern. And we also, know from this case that there will be changes in the knee, changes in the hip on the ipsilateral side, and also contralateral ankle. And which should be considered as compensatory changes. The value of gait analysis here is that it allows us to sort of note down the contributory factors from various joints. And it would also show us if there was a rotational problem. It would clearly pick up on the other graphs. So 2 excellent cases here and very good discussion. So I thank everyone for joining in and contributing to this. And as always, we'll be with you the second Sunday of next month, April 10th, right?
Yes, sir.
And then same time, 6 p.m., we are going to have a talk by Dr. Dhiren Ganjwala on normal gait cycle and a case by Dr. Jayanth Sampath. And then, Jayanth, before we sign off, any additional remarks you or Chasanal want to say something?
Anyone who is listening to this webinar, if you would like to join our movement analysis WhatsApp group, please contact one of us, Dr. Chasanal, myself, or Dr. Taral, and we will get you onto the WhatsApp group.
Thank you. With this, we can end the webinar, and I would request, while thanking OrthoTV for their support.
Thank you, sir.
Jayanth, are you on?
Yeah, I'm on.
Okay. So couple of things.